Hello, everyone. Welcome to the very first lecture, the first chapter of AMP2. I want to give a little outline, a little breakdown of kind of my expectations for every chapter when we look at this. But before we do that, let's just go ahead and get started with the autonomic nervous system, chapter 16. So what we are looking at is the system that when we were in AMP1, we discussed the different systems of the nervous system, different subdivisions, the somatic and the autonomic. So we are discussing the autonomic. And I always start each chapter off with a little quote. And the one that I wanted to start with here is one of the greatest discoveries a man makes, one of his great surprises, is to find he can do what he was afraid he couldn't do. So if you made it through AMP1, you did what you were afraid you couldn't do. So now you're here. So as we jump into this, you will see at the front, the second slide of any PowerPoint that I do has a list of chapter objectives. These are not from me. These are from the college. This is our objectives for every student who takes the course, the things they're expected to see and be tested on. So one of the things that I do is every one of these chapter objectives 1 through 12 will have a question on exam 1 on it. So you will have something on the autonomic plexuses. You will have something on the different types of neurons in the ANS. You will have sympathetic, parasympathetic receptors and neurotransmitters, those kinds of things. So make sure you are paying attention to these particular things that we're looking at. So, all right, so let's get started. So what I want to do before I do anything is remind ourselves of a few basic things from the first semester course at the very end. Since it's at the very end, students tend to forget those things. Now remember that we are dealing with a subdivision of the nervous system in the autonomic nervous system. Now we will get more into that in a minute, but one of the things we need to make sure we remember is that in AMP1 we saw that neurons were the cells that communicated. They are part of the neural tissues. That and glial cells, neuroglia cells, were part of those as well. Now, neuron being the main cell, the one that does the communication, we want to remember that there is a cell body, and the cell body holds the nucleus and most of the cytoplasm. That off of those are dendrites that receive information from other neurons. So right here we have a neuron's dendrite. We have a dendrite here, and we have these neurons here, the neuron here rather, connected to it, giving it communication and talking to it. The axon, the long thin fiber that comes off of the soma or cell body, is the thing that the action potential conducts down, the electrical impulse. At the end are telodendria, where you will find at the very tip end synaptic terminals or axon terminals that have the neurotransmitters stored inside them for the synapse. Now, we'll talk about neurotransmitters in a minute. Now, at the end of that, if we were to look at the synaptic terminal, we would see this expanded region containing vesicles that hold the neurotransmitters, different types. Now, here we have what is called a synapse. What is a synapse? That's just two cells come together to communicate. That's all it is. Two cells come together to communicate, to talk to each other. Now, to do that, there is a synaptic terminal and another cell. Now, the first cell is usually going to be a neuron, presynaptic, but it could be a very specialized type of receptor that is out there that we'll see in the senses. And then we're going to see there's a postsynaptic cell that follows after the synaptic cleft, the gap between the two cells. And this could be a muscle cell, or a gland cell, or any other kind of cell, or in this case, another neuron. So it is the cell that receives information, receives neuro commands from another neuron. And the gap between these was called the synaptic cleft. In AMP1, I talk a little bit about the fact that it's not touching, but not too far apart, because remember, diffusion is very inefficient over distance. So when the neurotransmitters are released via the presynaptic cell, those neurotransmitters go into the synaptic cleft, and they are going to bind to this area here on the postsynaptic membrane, the membrane that is found on the postsynaptic cell. That's where the receptors will be located. A great example of that was the motor end plate found in the neuromuscular junction there. So remember, the communication occurs using neurotransmitters at this particular this type of synapse. Remember, there are chemical synapses, etc. And sorry for that little quote mark there. I'm going to go ahead and remove that. It was bugging me. I always find sometimes little minor problems like that. Now, just as also a couple terms I want to remind you guys of, specifically terms like depolarization, hyperpolarization, and resting membrane potential. Those are three big ones for the actions we want to make sure we understood. Remember that resting membrane potential is usually about negative 70 millivolts, and this is when the neuron is not sending a signal. Now, when we depolarize it, the cell is becoming more positive and going in a positive direction, in this case towards negative 60 millivolts. Remember that negative 60 millivolts is the threshold for most neurons. And if you can depolarize it to that, you will form an action potential. The action potential is when a depolarization goes above to the threshold level and results in the firing of a chemical signal. An electrical charge is generated that acts as a signal. This is kind of why we might think of humans' brains much like a computer, is because we both use electrical signals to send information. In this case, our electrical signals, instead of being the flow of electrons, are the flow of ions, sodium and potassium ions in and out of a cell. Depolarization, remember, is when sodium flows into a cell. Repolarization is when potassium leaves and brings it back to resting membrane potential. At resting potential, a cell is said to be polarized. And then hyperpolarization is when you go below resting membrane potential, like right here, we are hyperpolarized. Now, that was just some of the basic review of the action potential and the electrical processes happening, because I might talk a little bit about that throughout this lecture, or I will talk a little bit about that throughout this lecture. All right, so let's step back and look at now the two divisions of your nervous system. And what I'm going to do is a little sketch here where we talk about our nervous system having two basic things. We have an area here consisting of our brain and our spinal cord. Brain and spinal cord. I'm going to abbreviate SC for spinal cord. And that is your central nervous system, CNS. The CNS, or central nervous system, is composed of the brain and the spinal cord. And everything outside of that was the peripheral nervous system, abbreviated here PNS. Now, what happens with your PNS? Let's say I've got an eyeball right here, and it's going to take a minute for this to register over the poor quality internet that I'm using here in the office at Northeast State on campus. So let's say you guys were looking out there and saw this lovely person that you saw. They were a very attractive person to you, and the light of them were to come to your eye. Well, your eye needs to be able to take information about that person, and with neurons, send that information to the brain to be understood. Now, that would be one job of the peripheral nervous system, is to send information to the central nervous system. Now, what if we wanted to go ask this lovely person out on a date? We might need to walk over to them and ask them if they would go out with us. Well, we would need to get our muscles involved. So right here, I've drawn a skeletal muscle cell. Here we have a skeletal muscle cell. It's going to appear on the screen in just a second. Again, I'm battling very poor quality internet. And we would have a neuron in here that would go out to that and tell that muscle to take us towards this lovely person that we want to go ask out on a date. So our CNS is the part of the nervous system that is receiving information and sending out motor commands. Okay, so here we have sensory, here we have motor. Okay, so with this in mind, let's take an idea of this whole thing here. Your central nervous system, remember, contains the brain and the spinal cord. It's in the center of the body. The brain housed in the skull, and the spinal cord housed in the vertebral canal. Remember, these are organs contained in the dorsal body cavity of the body, meaning it's in the center of the body. These are surrounded by axial skeleton. Peripheral nervous system is anything that is nervous tissue that is not central nervous system. If it's not in the brain and it's not in the spinal cord, then it is the PNS, peripheral nervous system. Now, here we sketched out these two terms, sensory and motor. So let's use some alternate names. Sensory. Now, if you look at that information is arriving to the brain to be understood. So if it's arriving, we can call this the afferent. Afferent, remember, equals arrives. Afferent arrives. Motor command is leaving the CNS. So here we have motor functions. We have motor. And this motor function that we have here, sorry, I needed to erase that, is exiting. And so one of the names given to motor commands is exiting is efferent, because that will exit. Exit. Efferent will exit. Afferent arrives to the CNS, efferent exits the CNS. Okay, so the afferent is what carries sensory information from any receptors that are out in the body, like in the eyeball, and carries that to central nervous system for me to be aware of its existence. The efferent division exits. It carries motor commands from the CNS out to any peripheral effector. For example, the muscle cell in my drawing here. In this drawing, I had a muscle cell, and this muscle cell would be an effector, but that also could be the smooth muscle in your blood vessels, or your heart, or any gland for that matter. So a cell or organ that responds is called an effector. Now, remember that with this, we have somatic nervous system. Now, somatic nervous system and autonomic nervous system are the two distinct motor pathways in the body that are the most important for us to understand. Now, we know we have some reflexive motor pathways, but these are the things that are the two diametrically opposed. Somatic is going to be voluntary control of skeletal muscle. Now, what is interesting about these is that somatic controls your skeletal muscle. Now think about it. Soma in a neuron was referencing neuron cell body. Somatic references skeletal muscle. What is it that makes up your beautiful body? That's your muscles. If you're very muscly, very ripped, you might have an awesome looking body. And that means your somatic controlling skeletal muscle. Well, skeletal muscles should be voluntary. Are they always? No. You might have a movement disorder. For example, Parkinson's disease, where you make unwanted movements, or Tourette's syndrome, which is actually what I have, is Tourette's, which causes involuntary muscle movements. Everything ranging from the motor tics to vocal tics. And then we have our autonomic, and that is unconscious. It's without conscious control. Now think about this. It controls your life support systems. You don't need to be able to think about your heart beating. You don't have to sit here and go heartbeat, heartbeat. You don't consciously think Breathe in, breathe out, breathe in, breathe out. If you didn't do this, it would kill you to go to sleep at night. A good night's sleep would be fatal because you wouldn't be consciously thinking, breathe in, breathe out, breathe in, breathe out, breathe in, breathe out. You wouldn't be thinking heartbeat, lub dub, lub dub, lub dub. You would just die if you had to consciously do this. So these are anything that work without conscious control or unconscious, subconscious. You do not control them yourself, okay? So if we think about somatic, controls your body voluntarily. Autonomic controls your body unconsciously or without conscious control. Now, if we start off at somatic, let's find the motor pathways. You might remember upper motor neurons and lower motor neurons from AMP1. The upper motor neurons for the motor system, they begin themselves up in the precentral gyrus of your primary motor cortex, the frontal lobe. Remember, the frontal lobe has a precentral gyrus located anteriorly to the central sulcus, and those neuron cell bodies send their neurons down, then they synapse somewhere with a lower motor neuron. And the lower motor neuron is the neuron that goes down either from the brain stem, for example, cranial nerves, or spinal cord down to control a muscle fiber. So the motor nuclei of the brain to your skeletal muscle fibers, they come from the midbrain, from the brain stem downwards. Now, if they don't go, they may not always go into the spinal cord like cranial nerves. They'll come out of the brain stem, bam, if they're a motor nerve. If they are spinal, they'll go down the spinal cord and then out to control the muscle fibers and innervate them. Remember, innervate means that it makes it function. That means there will be a neuromuscular junction present there. All right. Now, autonomic, we said it controls basic life support. So to do this, it controls smooth muscle. Now think about smooth muscle. It's located in your blood vessels. It's located in your respiratory system. It's located in a variety of places like the reproductive system, digestive system, areas in your body that you normally you have no conscious control over. Cardiac muscle is in your heart. You do not control your heartbeat. Glands, you cannot make your salivary glands produce saliva on command. Now, you can get yourself hungry and make them salivate, or put something in the mouth, and the salivary glands will stimulate due to the tactile stimulation, but you can't consciously make glands secrete. And adipose, you're not going to make fat break down. You cannot consciously say fat breakdown and it goes away. It's just not going to do that. It needs the autonomic nervous system, specifically the sympathetic division. Now, the ANS, remember, if it controls these cells, these tissues, then we would say it controls your cardiovascular system, your blood vessels and heart and blood vessels, respiratory, breathing, digestive, your gut, urinary system, your bladder and things like that, and your reproductive systems. So things like ejaculation or movement of gametes throughout the body will be controlled by autonomics, things like erections, stuff like that as well. Now, the hypothalamus is the integrative center for the autonomic nervous system. So instead of having that upper and lower motor neuron, the first neuron is up in your hypothalamus. That neuron comes down from the hypothalamus. Then there's two other neurons, and they're either going towards or away from autonomic ganglia. So in somatic, there's two neurons, upper and lower motor neuron. In autonomic, there are three. There will be the hypothalamus neuron, then the neuron entering a ganglia, and a neuron leaving a ganglia. Now, remind yourself, a ganglia is nothing more than a collection of neuron cell bodies in peripheral nervous system. All right. So here we have somatic. You're here in the precentral gyrus. Here's central sulcus, precentral gyrus out here somewhere. The neuron comes down, upper motor neuron. Now, like I said, it could come out from the brainstem's medulla oblongata and the brainstem come out, or that neuron may go all the way down to the spinal cord. And There we go. Let's fix that. I didn't want, I can't believe I didn't see the typo there. So let me just highlight that for you. I do apologize. Every now and again, I do catch these things. It is something that, oops, I was going to put a highlight on that. And but anyway. It's okay. Let me just make that red just so that stands out really quickly. Let you guys see that. Okay. So I do apologize for that. I usually catch them when I'm teaching, not when I'm just looking over the notes. Okay. Now, hypothalamus. All the neurons start in the hypothalamus. They go down to an autonomic nucleus, in your brainstem, and or an autonomic nucleus in the spinal cord. So that is the similarities here. The first neurons in the series in somatic go either for cranial nerves or for spinal nerves to the nuclei down there. Well, the first neurons here do the same thing. There's either an autonomic nuclei in the brainstem or an autonomic nuclei in the spinal cord. You should know that that autonomic nucleus in the spinal cord is lateral gray horn from AMP1. Now, from there, a neuron comes to an autonomic ganglia. Then synapses with another one here. So there is purple, red, and black. 1, 2, 3 neurons in a series, whereas in somatic, red and black, 2 neurons in a series. Okay? And remember, somatic controls skeletal muscles only, where visceral effectors, smooth muscle, cardiac muscle, glands, and adipose for the autonomic. All right, so those are some big things there. We've covered a lot of big ground already. Now, we said there's a ganglia. Now, let me get some terminologies here. So let's say right here we have a ganglia. Now, we've got to make this a ganglia. What is a ganglia? Ganglia is a collection of neuron cell bodies in peripheral nervous system. So that means I need to have some neuron cell bodies. Well, over here in the CNS, brain or spinal cord, there is a neuron that comes in and synapses here. And let's use blue here and draw the neuron it synapses with. And then let's come here and put the visceral effector. That's the effector cell. Okay, so if I've got a ganglia here, I've got a neuron here that is leaving the CNS for the ganglia. That neuron is referred to as before the ganglia, preganglionic. Preganglionic neuron. That is a preganglionic neuron. Now, the one that leaves the ganglia to the visceral effector comes after the ganglia, so it's post what? Post ganglia, ganglionic. It is the postganglionic neuron. And this is the neuron that directly innervates your visceral effector. Your smooth muscle, cardiac muscle, glands, and adipose cells would be directly under control of a postganglionic neuron. The preganglionic neuron leaves the CNS, goes to a ganglia. From the ganglia, we have a postganglionic neuron to our effector cell. And think of this like a relay race, okay? So our relay race, we have our first runner. Runner number one is going to be our preganglionic neuron. The preganglionic neuron, remember, visceral motor neurons come out of the brain or the spinal cord. Those neurons are the preganglionic neurons. They go from CNS to the autonomic ganglia. The autonomic ganglia, remember, is a collection of neuron cell bodies found in the peripheral nervous system. Now, their axons of the preganglionic neurons are called preganglionic fibers. A fiber is an axon. Nerve fiber, neuron fiber, preganglionic fiber is the axon of the preganglionic neuron. Now, the preganglionic fibers, they are coming out of the CNS. They are leaving autonomic nuclei found within the brain or spinal cord. Now, they're either the nuclei there. Now, then they go on to make the postganglionic neurons, where they synapse in a ganglia. And that forms postganglionic neurons, or sometimes called ganglionic neurons. And the autonomic ganglia, the cell bodies that come out of the spinal cord, that is found in the lateral gray horn or in parts of the brain, what we refer to as the nuclei of the brain, those neuron cell bodies that come out of preganglionic fibers, preganglionic neuron cell bodies. They are leaving the lateral gray horn or the brain's autonomic nuclei. Now, then we go out to the ganglia. The ganglionic neurons is what controls our smooth muscle, cardiac muscle, adipose glands, things like that. Smooth muscle, cardiac muscle, glands, and adipose. That's usually the order that I mostly say it in. That the ganglionic neurons are the control cells. These are the visceral effector controllers. They control the cells the autonomic nervous system controls. Now, the ganglionic neurons, we call that a postganglionic fiber, is its axon. The axon of a ganglionic neuron or postganglionic neuron, that is what we call a postganglionic fiber, and they go from the ganglia to the target organ. Now, why does this matter? Well, just like in nervous system stuff, you could have diseases called upper motor neuron lesion or lower motor neuron lesion, and that could cause problems with people's movement. For example, for that one, you might remember my AMP1, we talked a little bit about Brown-Sequard syndrome. Well, here we could get lesions of damages to ganglionic neurons pre and post, and you get what is called an autonomic neuropathy. And this can happen from complications from diseases that happened that could cause neuropathy, like diabetes, for example. It can damage autonomic neurons rather than somatic neurons. So it does matter a lot in terms of you guys understanding things from pharmacology and med surg that you take if you are a nursing student. So runner number one, our preganglionic neuron, is going to be like our first runner. Now, when a runner needs to pass off to the next runner, you pass off a baton. Well, in this case, batons are neurotransmitters. So that means the preganglionic neuron will synapse with the postganglionic neuron, and there will be a neurotransmitter release between the two. Between pre and post, there is a synapse, and there will be a neurotransmitter released. Then runner number two, the postganglionic neuron, it releases a neurotransmitter. That means it got us to get the baton to the finish line. What's the finish line? That's your effector cells. That's smooth muscle, cardiac muscle, glands, and adipose. Okay. Now, you may be, as many times as I've said this, you might be expecting I'm going to ask you the 4 effector cells of autonomic nervous system, and you would be right. You're probably going to be guaranteed to see that in the future. It's a big thing. We have to understand that because in pharmacology, lots of drugs that affect these. If they affect smooth muscles, they can affect the heart, for example. They can affect glands, things like that. So you'll begin to discuss lots of autonomically active drugs. This is one of the hugest chapters for pharmacology that you ever learn. Okay. Now, So we learned that in Autonomic, back in AMP1, we saw that there was sympathetic and parasympathetic divisions of the autonomic nervous system. And they are two opposites. Now, here I don't have that yet, and now is when we're introducing that. Is sympathetic and parasympathetic divisions were the two opposite things. They are opposites. What one does, the other one does opposite. Now, sympathetic functionally, I like to call it fight or flight. Fight or flight. You might hear me refer to it as feed, flight, fight, and fornicate. Well, partly because the hypothalamus we know is involved in feeding, fighting, flighting, and fornicating, the four F's. Well, sympathetic is your fight or flight. This kicks in when you're stressed, when it's an emergency, when you're exerting your body. Like if you were to start running a marathon and you're really exerting your body, sympathetic is going to kick in. Stress is going to kick in here as well. And this is where people start getting anxiety attacks, is basically your sympathetic fight or flight system is kicking in, something that's supposed to be reserved for when you're having an emergency, a life and death situation. But here you are in traffic getting worried about being late from work. Is it really life and death? But you're treating it like it is. And you're having that impact on the body equivalent to a life and death situation. So sometimes ask yourself, is this really life or death? But it's emergencies, stress, exertion. Okay. Now, the first thing we're going to do is sympathetic. This is why when everybody's like, oh, I'm stressed before the test. Good. It makes you more alert. Stress is going to make you guys more mentally alert, which means your mental acuity is firing, your brain is firing. You're on this mental kind of edge where you're waiting just to be able to um, like mind like a steel trap. I don't know if you're like me, but I have a mind like a steel trap. Everything that goes in gets mangled. Okay. Now, we are going to see that it dilates your pupils. Dilation of the pupils is one of the causes of that is sympathetic. If somebody, for example, is taking cocaine, their pupils will be hugely dilated as it is stimulating the sympathetic nervous system. This is why you don't see coke addicts who are usually overweight. They're usually very skinny. And if they have ever taken a sympathetically active drug that they may have OD'd on, they will have dilated pupils. Increased metabolic activity. This is why people who take a lot of stimulant drugs like crystal methamphetamine, MMDA, if you're talking about things like ecstasy, amphetamines, these are things that increase metabolic activity. People who have died on some of these amphetamines, heart gives out, things like that. Reduce digestive and urinary functions. When you're stressed, you may not feel like eating. You may be a nervous peer. If somebody is very stressed when they go to the bathroom in public places, may not be able to go to the bathroom because they're nervous peers because sympathetic innervation is trying to shut that down. Now, sympathetic is interesting. There is clamping down of the smooth muscles can cause people to defecate on themselves upon death with a complete surge of right before they die. The sympathetic nervous system is like last ditch effort to try to bring you back. Also, we activate energy reserves. What does that mean? That means breaking down fat. Sympathetic, when you start to exert your body, you're going to start to increase metabolic actions and need your energy reserves. You're going to start to break down glycogen. You're going to start to break down fat. You're going to start to try to turn other things into glucose for the body. We're going to breathe harder and dilate our airways. We're going to breathe faster, deeper, and our airways are going to open up. If you've ever had somebody who, let's say, has a severe allergy to peanuts, and they eat peanuts and their airway closes down, and they become very constricted, and you give them epinephrine, epinephrine stimulates sympathetic dilation of airway, opens up their airway, makes their heart rate go up. It also, like I said, opens the airways, makes you start breathing harder, increases heart rate, gets your blood pressure up. One of the reasons we might give epinephrine to somebody is try to get their cardiac output up, get their blood pressure up, their heart rate up. Also, sweat glands. Now, think about sympathetic as having a panic attack. You've got beads of sweat. Your heart is pounding. Your blood pressure's up. You're breathing fast. You're hyperventilating. Things like that. You are pupils are just big. You're stressed out. So it can become very dangerous for people who have constant anxiety. Can become a problem. So, and you will deal with people who have those problems as well. All right. Now, parasympathetic. I like to call it rest and digest. Some people call it relax and repose. Rest and digest. This means when you're resting, it kicks in. Like, okay, everything's safe, everything's normal. You're chilling at home, you're relaxed, you're there, you're safe and sound. Now, that's when our pupils constrict. Now, parasympathetic drugs can make pupils constrict. They become constricted and fixed. Things that are parasympathetically active. Some drugs out there, like muscarine, for example, is a type of mushroom. It's a red mushroom with white dots on it, Amanita muscaria or fly agaric. People, take certain mushrooms as recreational drugs. This is you may be familiar with little brown mushrooms called psilocybins. A little bit different. They work with dopamine. Now, you also can decrease the metabolic rate. Now, when parasympathetic nervous system is activated, you're not consuming as much ATP. You're not making ATP as much. You're not consuming as much glucose. Your body is rebuilding its reserves. Your heart rate goes down. Your blood pressure drops. You start breathing easy because you're safe. You can breathe easy, but your digestive system goes up. Blood flow there goes up. You also will have salivary glands start to secrete. Motility and blood flow to your digestive tract goes up in anticipation for a meal. And you start to be able to urinate and defecate more easily. Now, one of the reasons people often defecate upon death is, we'll talk about later, is the smooth muscle contractions that occur in the gut to try to reduce movement through the gut can sometimes cause a bowel movement to occur. People defecate on themselves. But now you can urinate and defecate. Now, there's some other things our book doesn't really go into on this list of how parasympathetic and sympathetic affect reproductive functions. If you ever have to know it, here's how I remember reproductive action and which division does what. So you have erection, ejaculation, and orgasm. I always remember point, shoot, score. Point, erection, parasympathetic. Shoot, ejaculation, sympathetic. Score, orgasm, sympathetic. Point, shoot, score. It's a good way to remember it if you ever run into it in future classes, especially when you guys deal with people with some why a lot of medications they take to control their blood pressure will ultimately cause people to have loss of functions is you're trying to dilate blood vessels, things like that, and you can end up messing up people's ability to achieve erections because of the way you're affecting blood pressures. Things like that. So, all right. Now, there is a third that I want to mention. And this is called the enteric nervous system. It is found in the walls of the gut, in the digestive organs. It's found like in your intestines, your stomach. And it's got sympathetic and parasympathetic control both. Think of your enteric nervous system as a part of the autonomic that has two masters, two bosses. And the bosses, sympathetic and parasympathetic, affect it in different ways. Now remember, parasympathetic is rest and digest. So parasympathetic is telling enteric, work hard, work fast, work more. Digest, work, move that food. Sympathetic is going to be the sympathetic boss to the gut. To enteric, sympathetic is the sympathetic boss. He's going to look at the enteric nervous system and says, take it off. Take some time off. Relax. Enjoy yourself. Rest. It's okay. Together, this regulates digestion. There's times that digestion needs to go up, and there's times digestion needs to go down. All right. So, what I want to do here is begin to do another drawing. I'm going to start it off so you guys can do this with me. And I'm just going to kind of go in here and do my basic, let me erase that, make it black, because I'm going to need the colors in a minute. There will be some things I'm going to add to some drawings in a minute. But let's draw our very basic central nervous system drawing here. And then what we're going to do is right on this side, I'm going to write sympathetic, sympathetic, sympathetic. And over here, I'm going to write parasympathetic. Okay. Now, brain. Excuse me, spinal cord. Sorry, I'm just now getting over a head cold. Okay, so if you got that with me, brain, spinal cord, things like that, we're going to come to that in a minute. Okay, so let's start off with sympathetic and look at how it's organized. Now, we are going to be talking, remember, there was a neuron from the hypothalamus that comes down to the brain stem or to the autonomic nucleus in the spinal cord. So it's either coming, so the first neuron from the hypothalamus goes down to the brain stem or the spinal cord. Now, given that, then we remember we should have that in our head from earlier on in this chapter. So with that, we're going to be talking about the pre- and post-ganglionic neurons only. Just don't forget there is a third one up there. Now, from the hypothalamus down to the pre. Now, first off, we're going to see that the preganglionic neurons are short in what is called the sympathetic. They are short preganglionic fibers, and they are going to be found in the thoracic and lumbar regions, upper lumbar, thoracic and lumbar regions. So what I'm going to do with spinal cord is, let's just say right here we have, so let me erase SC. We should know that spinal cord. And I'm just erase it here. We have a cervical spinal cord, you know. We know that there's a cervical region to the spinal cord here. And we know there is a cervical. We know there is a thoracic region. We know there is a lumbar region. And we know there was a sacral region of the spinal cord. And then there was coccygeal down here. And we know those existed from AMP1. Now, sympathetic is called thoracolumbar. What's another name besides thoracolumbar that we should know? We should also know that it is fight or flight. Fight or flight. You either are going to stand and fight or run away when you're faced with danger. Now, it's called thoracolumbar. Why? The preganglionic neurons, let's use red, come from thoracic region and lumbar region of spinal cord here. So these will be the preganglionic neurons, and they will leave thoracic or lumbar. Now, they are very short pre. Now, that means they will have a post-ganglionic neuron that is very long. Let me move post up here at the top. So they have a long post and a short preganglionic neuron. And just so we're doing this, let's make sure to draw the ganglia around those. So the ganglia are nearby the spinal cord in the sympathetic division. Okay, so these are things I'm going to ask you guys potentially on a test is like in the sympathetic division, pre-ganglionic neurons are short versus long post-ganglionic neurons. I'm going to ask you about that kind of stuff, okay? So post. Okay. Now, where does that actually begin? T1 to L2. T1 to L2. So what we want to do is come into here with T1 down to L2 levels. So the preganglionic neurons emerge between T1 vertebral level to L2 vertebral level. So T1, T2, T3, T4, T5, T6, T7, and T12, L1, L2. Okay, so that's one drawing here with some information. That's one half of it. Okay, now, so the ganglionic neurons come out of the lateral gray horns between T1 to L2 of the spinal cord, so we call it thoracolumbar. Now, the ganglia are near the spinal cord. Since they're near it, they have short preganglionic neurons and long postganglionic neurons in the sympathetic division. And here you can see a good diagram of that. So here we have sympathetic, T1 to L2. T1 to L2, the preganglionic neurons come out. Now remember, from up in the hypothalamus, there are neurons coming down to each one of these red ones. The red ones go out to an autonomic ganglia nearby the spinal cord, and then the black lines are very long, short pre, long post to the effector cells. Smooth muscle, cardiac muscle, glands, okay? So smooth muscle, some things in the smooth muscles, glands, smooth muscle, glands, smooth muscle, glands, things like that, okay? So we will see that it comes from thoracolumbar, short pre, long post. Now, the next one is parasympathetic. Now, parasympathetic comes from the brain and spinal cord. So, brain and spinal cord. So, it's either coming from the brain, the pons and medulla oblongata, brainstem, or out of the sacral spinal cord. Okay, so here what we're going to do is let's get our brain, long, or sacral, long, and we will see that the pre's are long and the posts are short. So what you're seeing here is complete opposite of the sympathetic division. Now, what do we call this? Well, remember, parasympathetic was sometimes called rest and digest, but we also call this craniosacral. Why? It either comes off the brain or sacral spinal cord. Okay? A lot of good information so far in that drawing. Now, the sacral spinal cord is S2 to S4. So what we're going to do, the last thing I want to do is make sure we know it's S2 down to S4 vertebral level. You will find those coming through. Then lastly, we want to put the ganglia far off. The ganglia are far off here, away from the central nervous system, further away, because of the long preganglionic neurons. Now, I'm going to ask these kinds of structural differences between sympathetic and parasympathetic divisions. So do be highly aware of that. If you're looking at the chapter reviews, you'll see that. Some stuff that I'm going to be asking you guys about there. Sorry, clicked the wrong thing. Now, Um, so we come from the lateral gray horns in the sacral region, S2 to S4, craniosacral. So the ganglia are generally not very near the spinal cord, so they're going to be a little bit further away, as you can see. So I need to fix that. That should not be near spinal cord, away from spinal cord. Um, Sorry about my typo there. Okay, so now the preganglionics are long and the posts are short. Now this is something you have to work on getting in your head. It does not pop in easy. Okay. All right. Good. Okay. These aren't things that are going to come in easy, but let me flash this up on the screen so you can draw that. Take a pause, save it, take something with that. It is a lot of useful information in one drawing right there. Okay. And you can see here, either from the pons medulla oblongata or S2 to S4 vertebral level, preganglionic neurons leave. Here, the ganglia are going to be very close by the organs themselves, so the ganglia are going to be far off. Here, for example, these ganglia are quite far off from where the preganglionic neurons are. So what we're going to see is we go all the way there, then there's a ganglia, then we go. There will be some ganglia that we'll talk about, especially sympathetic ganglia, more about that. But right now, let's take a look how the pelvic nerves and things like that, and the cranial nerves. Now we're going to get more into that. So we're going to eventually put everything here in place. Specifically, what I want to do is talk about, because these they're very far away. That's why we said intramural. They're usually in the organs that they control, so they're very far away. And I'm just going to say very far away, and that will be simply enough there for us in this level. Now, sympathetic ganglia. So if we want to go back and look right here, this image, we can see there's some ganglia here, here, here. Here's some other ganglia here as well. Here, some ganglia. Here's some ganglia, some ganglia. Okay, so we can see some ganglia, collections of neuron cell bodies in the CNS, or in the PNS, sorry. All right. So as we think about that, there are three types of sympathetic ganglia. The first one, there's many of them, is called the sympathetic chain ganglia, or paravertebral ganglia, or paravertebral chain ganglia, sympathetic trunk ganglia, some people call it. These chain ganglia run as a chain, like beads on a string, along the spinal cord right here. Okay. And they run this length. So these guys are on the lateral sides of spinal cord. They're located besides the spinal cord. Not these. These are the dorsal root ganglia. We're talking about these autonomic ganglia right here, the sympathetic chain ganglia here and here, lateral to the spinal cord. They control things found in your body wall, thoracic cavity, head, and limbs. For example, they'll go to control your lungs, your heart, your salivary glands, some of the skin and things like that, the arms. If you go look at some of the, like here, if this was skin of the arms, for example, neural control of sweat glands in the arms, things like that. Okay. Give you goosebumps, things like that in the arms. Now, the collateral ganglia are located anteriorly to spinal cord. Here's spinal cord. In front of it is collateral ganglia. This is going to be carrying any organs in the abdominal pelvic cavity. If you look back here, what you're going to see is these guys right here controlling abdominal pelvic cavity organs. This is everything down below the thoracic cavity. And suprarenal medulla. This is, right here we have our adrenal glands. They sit above the kidneys, hence supra, above, suprarenal kidney. Above the kidney is a gland called the suprarenal gland. Inside that gland is a layer called the suprarenal medulla. And the suprarenal medulla, being on top of the kidneys here, is the very interesting area for sympathetic ganglia. Right here, you can see them here on top of the kidneys, but not showing the neuron. Okay, this is what's interesting. Here you can see, sorry. Here you will see that this preganglionic neuron is very long, and the postganglionic neuron in the adrenal medulla is very short. This is the only place in the sympathetic division this happens. Now, I could tell you guys that boards and standardized tests love exceptions to rules, and this is an exception to the rule that sympathetic preganglionic neurons are short, postganglionic neurons sympathetically are long. So remember, sympathetic has short pre's, long posts, sympathetic, not here. In this case, the preganglionic neuron is very long and the postganglionic neuron is very short. Now, this is very weird. Now, what happens is the only place this happens. Now, it's short because it goes into the bloodstream or general circulation. This allows us to dump the neurotransmitters into the blood, and instead of being a neurotransmitter, it's now a hormone because it's in the blood. Remember, hormones go into the blood. Remember back in histology section A&P1, we saw that endocrine secretes endoblood. Endocrine endoblood. We saw that a cell that secretes a hormone into the extracellular fluid that then diffuses into the blood to make its target cell is referred to as a hormone. Well, that makes these neurotransmitters now hormones. Because of this, it allows it to have the longest action in the body, very long-lasting actions. So this is your adrenaline rush. When you guys have adrenaline surges, it takes a long time to come down from it because of this. And this allows me to attack the entire body sympathetically, affect every tissue throughout the body who needs to get sympathetic innervation, even if there are no neurons present. Now, let's look at this a little bit more in depth, okay? Now, you guys may deal with patients who have had injuries to their spinal cord, and they may have damage to chain ganglia, so you need to know a little what's going on here so you understand some of the autonomic dysfunction and somatic dysfunctions of your patients and how certain injuries in certain areas may affect different things, especially if you work in neuro ward, things like that. Now, as you think about this, we're going to start off with our sympathetic chain ganglia. Now, the chain ganglia, remember, this makes your rami communicants. If you remember the rami communicants from A&P1, this is one of the last things we did when we did spinal cord, spinal nerves in the last two classes. It's one of the last things, and this is one of the things we saw in the nervous system. First part of the nervous system was spinal cord, spinal nerves. And you guys would have seen the two rami communicants, and they are on the sympathetic trunk ganglia. Now, what that is you have these little guys here called a white and a gray ramus. Now, think about the sympathetic chain ganglia. The rami here, I like to think of them as backwards Gandalf. Now, if you've never seen Lord of the Rings, most of you have heard of Gandalf. Now, Gandalf was the wizard in the Lord of the Rings. Now, if you guys watch Lord of the Rings, you know that Gandalf started off the Lord of the Rings as Gandalf the Grey. That's how he started. And he ended Gandalf the White, after he died with the Balrog and he comes back. Well, after he resurrects, essentially. So what happens is, this is backwards Gandalf, because Gandalf came in gray and left white. Well, what do we do here? We come in white and we leave gray. The white ramus is myelinated. That's where it gets its name. And that's where the preganglionic neurons enter the ganglia. We come in white, then we leave gray. We leave gray is unmyelinated, and that's where they leave to go to the effector cell. Now, if they don't, they may go out what is called a splanchnic nerve. Splanchnic nerve is another way they'll leave. What is referred to as a splanchnic nerve or sympathetic nerve. All right. Now, collateral ganglia, remember, are located anterior to the spinal cord. Here we have our sympathetic chain ganglia. Here we have collateral ganglia. Now, there are three that we need to know about. There's a celiac ganglia, superior mesenteric ganglia, and inferior mesenteric ganglia. Now, let's go back to this diagram. This diagram right here is this one here, celiac, superior mesenteric, inferior mesenteric ganglia. Okay. Now, the celiac ganglia controls things like your stomach, your liver, your gallbladder, your pancreas, and your spleen. Now, why does this matter? When you have injuries to these ganglia due to trauma, gunshots, stab wounds, patient will have some problems controlling these things, and you got to be able to look for that. If they can't control some of these things, they're going to have certain dysfunctions. Now, the superior mesenteric ganglia controls your small intestine and most of the large intestine. We call that the first 2/3. The inferior mesenteric ganglia controls the rest of the large intestine, rest of the colon, but it also controls your kidneys, your bladder, and your sex organs. Now, you could see these here, okay? We could see liver, gallbladder, things like that, okay? Stuff like that. Okay. Adrenal medulla. Now, this is the only place where the sympathetic division has long preganglionic neurons and short postganglionic neurons. And this is the only place this happens, where the preganglionic neuron comes into the adrenal medulla, and at the adrenal medulla, it synapses with a neuron, and that neuron is called a neuroendocrine cell, because it is a neuron that releases hormones into the blood, making it endocrine, and a neuron, both neuroendocrine. And these neuroendocrine cells make two kinds of materials. It makes epinephrine. We know epinephrine, and referred to as norepinephrine. Now, epinephrine is sometimes called adrenaline. Norepinephrine is sometimes called noradrenaline. Most people nowadays, today, you will usually hear epinephrine, norepinephrine collectively called adrenaline, but older people will call adrenaline means epinephrine. For them. So really got to be careful. Make sure you make that delineation. I'm just going to say epinephrine, norepinephrine on my exams, just to be safe. Epinephrine is 75 to 80% of what is released here, and the remaining 20%, let's say, is 20 to 25% remaining is norepinephrine. Now, this, remember, allows a long last because hormones, they're going to be in the bloodstream. They're going to allow me to have a long-lasting impact than neuro. Because remember back at A&P1, something I know I talk about in Chapter 1 is that nervous system and endocrine system both control the body, but in different ways. And I always say the nervous system and the endocrine system are so different that it's like the tortoise and the hare. If you guys ever remember that parable, the tortoise and the hare, that fable, that slow and steady won the race, the tortoise, well, that's the endocrine system. The hare, the rabbit, was the nervous system. Fast, it's fast, but it's over quickly. Endocrine is long to last and slow to act.
So this has a longer result because endocrine is very slow. All right, now this would be a great time to pause. Go ahead and pause. Come back to this because we are getting ready to hit the physiology end of everything. Now we got the structures. We're going to hit the physiology. Come back to this, okay? Okay, so I hope you guys enjoyed your pause. You notice I didn't really pause. I just took a breath. And what I'm going to do is talk about two important terms. You need to have these in your forever brain. These are huge. This is a big deal for us to understand these two terms, okay? They're really big deals when you go into things pharmacology for different programs. Now, the first thing we want to talk about is the two different types of neurons that are found in the autonomic nervous system, ANS, and we're going to describe them based on what neurotransmitter is made. I apologize, my phone rang, so I had to stop. So again, I was saying that there are two ways we can classify the neurons of the autonomic nervous system based on what neurotransmitters they are releasing, secreting here. So let's look at these. Now, the two names that we're looking at is cholinergic and adrenergic. Now, these names tell us a lot. First off, cholinergic. When you see this colon, think acetylcholine. Choline, cholinergic. Acetylcholine is the neurotransmitter of a cholinergic neuron. The neuron found in the NMJ, that's cholinergic. Adrenergic, that's adrenaline. Because a lot of times we will say adrenaline, modernly, is epinephrine and norepinephrine collectively. Now, some folks now will say that adrenaline is epinephrine and noradrenaline is norepinephrine, but we're going to say epinephrine, norepinephrine is adrenaline collectively, and we'll just be done with it, okay? Now, neurotransmitters here, epinephrine, norepinephrine, adrenergic, adrenaline, cholinergic, acetylcholine. Okay, so these are two very big, important definitions and terms we must know. They're huge. You will see this all the time. So it's a very big deal. Cholinergic, adrenergic. Okay, now for these cholinergic, adrenergic neurons, they are, in order to get a sympathetic nervous system to do its job, we have to have receptors. Now, think back to AMP1. Now, I talk about this in AMP1. I don't know if your instructor does, but AMP1, I make the comment that it's all about the receptor, especially when I discuss excitatory versus inhibitory postsynaptic potentials in a neuron. As I say, it is all about the receptor. So this means we need to take epinephrine, norepinephrine, and bind it to a receptor, an adrenergic receptor. Now, think of epinephrine here. Now, epinephrine can bind to both types of these receptors. They can, though one is better than the other in some respects. But let's just say that we have epinephrine. And epinephrine goes in. Epinephrine is a young lady who is, that's her name, is epinephrine. You can imagine that might be somebody's name nowadays. Somebody's named their kid Epinephrine, and they go out to a club, and they're going to dance with some guys at the club. And the first guy that they come to dance with, her first dance partner, is he's wearing the trendy clothes of today. Like what you would expect a guy going out who's a modern guy wearing the trendy cool clothes for what somebody be wearing at a hip club. Obviously, I've never been to one because I said the word hip. I don't know what the people dress these days. I don't know. But they're dressed cool. They're dressed in the modern, trendy, fashionable outfits for going out to the club. And she dances with him, so she dances the latest dances with him. She's going to do whatever the latest dance crazes are. But then if she sees a guy wearing a tuxedo, she goes and dances with him, and they ballroom dance together at the club. And the next guy is wearing tight Wranglers and a button-up white shirt and a cowboy hat and wearing cowboy boots. She's going to country line dance with him. She is the same woman, but the different receptors, dance partners, gave different responses. Now, there are two classes of adrenergic receptors out there, alphas and betas. Kind of like there's alpha males and beta males. Now, let's look at this. Let's say if you have epinephrine or norepinephrine here, and these molecules were to make it to a receptor, either an alpha or a beta receptor. Now, it can bind to either one of these, okay? Now, on alphas, we're going to see alpha 1, alpha 2. Betas, we're going to see beta 1, beta 2, beta 3 receptors. These are on effector cells. These will be located on your effector cells that are under control here. Okay, so what we'll note is that these guys here is that alphas, though, like norepinephrine the best. So for an alpha, if I always say like epinephrine is you, your girlfriend is alpha receptor, and norepinephrine is the guy that she tells you not to worry about. So it's like, hey, here you are, you're epinephrine, you're dating an alpha receptor, and norepinephrine is the guy she tells you not to worry about. You're going to see that it's more stimulated by norepinephrine, gets a greater response, it's more sensitive to it, it prefers it. But beta adrenergic receptors they're fine with either one, either or, epinephrine or epinephrine. Now, alpha 1s, alpha 2s, which there are alpha 1, alpha 2s, is alpha 1 is by far the most common. Now, alpha 1's the most common type. They're going to be found in smooth muscles in your gut and urinary system. So what do? They constrict things like sphincters. They pinch the sphincters down. They are going to cause sphincters to close and reduce food moving through. They're either going to cause reduction move through sphincters, and they're going to cause decreased urination. Now, they use what's called G-protein linked. Now, what does it mean to be G-protein linked? G-protein linked is kind of complicated to talk about. So let's imagine a G-protein linked receptor a little bit here, okay? This is difficult to think about. Now, G-protein linked receptors, here you have snuck out of your house at night, and here's your bedroom. You need to get into your bedroom. You've snuck out of the house at night to go to a concert that you shouldn't have snuck out to. Now, if you go through the front door here, Mom and Dad's going to find you if you sneak through the front door, and you're going to get caught. So what you wanted to do was sneak up through the window here, but you can't get in. The window's locked. And inside your bedroom, I want you to imagine that your little brother or little sister's up there too. Now, your little brother and little sister is like a G protein. Now, if you knock on the window, tap, 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 little brother or little sister could open the window and let you in. You were able to sneak in the house. Mom and Daddy didn't know you snuck out to go to the concert. You got away with it. Or little brother or little sister can just say, I'm not letting you in, leave you outside in the cold. You get caught because, well, you either have to go through the front door, you didn't come home last night, you got caught, and they find you asleep outside. And, well, obviously you did something bad. Or little brother, little sister can go, Mom, Dad, they snuck out to go to the concert and you got in trouble. So they could get you busted, they could not let you in, or they could let you in and be a cool little brother, little sis, let you in, let you get away with it. And that's what G proteins are like, is your little brother, little sister who you've snuck out of the house to go to a concert. You want to climb up and sneak in your bedroom window, and little brother, little sister is the one responsible to let you in. That's what a G protein is like. They allow different responses depending on the signal. Okay? Now, alpha 1s, smooth muscle GI tract, urinary tract. The G protein can let calcium enter, exciting the cell, so that will cause constriction of sphincters, constriction of muscle tissues, reduction of moving through sphincters, contraction, things like that. Okay? Now, it's also a vasoconstrictor, alpha 1s. Vasoconstrictor. Alpha 2s, what do? They lower a thing called CAMP. They lower CAMP activities. Now, that's something we will learn about in AMP2 in the endocrine system. We'll get into endocrine system later on. It's a second messenger system. We'll see it in the endocrine system right now. Alpha 2s lower CAMP. It also causes the reduction, stops the release of norepinephrine, and it relaxes the GI tract. Okay, GI tract muscles become relaxed, the sphincters contract, so food doesn't move through with alpha 1s and alpha 2s. So alpha 1s, you contract the sphincters, reduce movement, contract the sphincters. You don't move things through sphincters anymore. So what we see here is we relax smooth muscle, so food isn't moved through anymore. We just stop moving food through the gut. Food isn't going to be moved because the sphincters can contract with that. Okay, alpha 1s contract the sphincters. Alpha 2s relax the gut, and they stop releasing norepinephrine. I'll show you what I mean by that. With alpha 2, this is something that happens with an alpha 2, is on alpha 2s here, let's say that I have a cell here that's wanting to respond to, let's say I have alpha 1 here, okay, on this cell. Alpha 2 would be here. And this cell here, if it released epinephrine or norepinephrine, and that binds to this, the norepinephrine can't be released anymore. If this was a cell here, releasing norepinephrine, this norepinephrine can bind to this and shut off its release. And that's what it does, alpha 2s. Or it relaxes the gut. That's the other action. Now, I'm going to ask one of these two, okay? One of these two. They will be on the test. Alpha 1s, alpha 2s. Now, beta receptors, beta 1, beta 2, beta 3. You will see one of these as well, okay? Beta 1, beta 2, beta 3. There's beta 1, beta 2, beta 3. What is beta 1? Beta 1, if you activate it, it increases the heart rate. Now, it excites the heart cells. Now, if we use a beta blocker, beta blockers prevent them from being stimulated, lowering the heart rate. It prevents and blocks the action of increased heart rate. They're found in the SA node and AV node of the heart. Beta 1s. Beta 1s, beta blocker. That is the beta 1 adrenergic receptor blocker or antagonist is the thing given to people to keep their heart rate down. We give people beta blockers. Now, there's many types of beta blockers. Now, we want beta 1 specific. Now, here's where it gets into problem, is there are very specific beta blockers, and there's very generalized. Very generalized beta blockers can affect beta 2s. Beta 2s are activated to relax and dilate the respiratory tract. They act as bronchodilators and vasodilators of the bloodstream. Okay? Now, given that, these vasoconstrict. Alpha 1s vasoconstrict. Beta 2s vasodilate. Okay? Now, here's something that I have used in the past to help my students remember that particular thing. Is I want you to think about your ABCs. We know that A, B, C, D. Alpha 1, beta 2, alpha 1 constricts, beta 2 dilates. Okay? That's a handy mnemonic there. And I'll leave that mnemonic up on my screen. I'll put it back up. So, beta 2s, bronchodilators, and vasodilation. Let me just kind of get rid of that. It's bugging me. And every time I'm teaching it, I'm aware of it, but not when I'm just looking at it. Beta 3s are on adipose, and they help me get energy demand. Remember, metabolism goes up during activation of sympathetic division. So beta 3s, they break down adipose. We call that enhancing lipolysis. So beta 1s increase heart rate. Beta blockers go against this. This is called a beta 1 adrenergic receptor antagonist. Beta 2s, bronchodilation, vasodilation. Beta 3s break down fat. Now, another thing is there is a gas to relax smooth muscles called nitrous oxide. Nitrous oxide becomes a smooth muscle relaxer. And this is why nitrous oxide is used to get people relaxed during like dental procedures. All right. Now, one of the things I want to make sure, so again, before I move on, use this. This is a great mnemonic. Alpha 1s constrict, beta 2s dilate. Okay. Now, parasympathetic division, we know is craniosacral with long preganglionic neurons and short postganglionic neurons. Now, we know that it comes from S2, S4 vertebral regions of the spinal cord and the sacral segments of the spinal cord. There are lateral gray horns at S2, S4. Now, we do know it's cranial, but what nerves? 3, 7, 9, and 10. 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 Bop your head when you sing it. 3, 7, 9, and 10. 3, 7, 9, and 10. Parasympathetic, cranial nerves. 3, 7, 9, and 10. 3, 7, 9, and 10. 3, 7, 9, and 10. You'll get them in your head when you do that, okay? So this is 3, 7, 9, and 10. Oculomotor, facial, glossopharyngeal, and vagus. Okay? Now, so those are big. Big, 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 big. You need to know that, okay? I would say wink, wink, nudge, nudge, say no more, but you need to know that. Okay. Now, 3, 7, 9, and 10. It is 3, 7, 9, and 10, the oculomotor, facial, glossopharyngeal, and vagus. Now, vagus nerve is 75% of all parasympathetic innervation. So he does all this stuff. Now, mostly this stuff does the head. Like stuff in your head, like oculomotor controls things like your tear production, controls things like the diameter of the pupils. Facial controls things like the salivary glands. Glossopharyngeal controls some of the things in your throat, things like that, tightening up your throat. But vagus is mostly down below in 75%, and it does neck, thoracic cage, chest, and abdominal. He is huge. Vagus is extremely important, okay? 75% of parasympathetic innervation is the vagus, and the vagus goes around. That's where it gets its name. He wanders to the neck, the chest, the abdomen. Why does it call the vagus nerve? He's a vagrant, a vagabond, a nomad, a wandering nerve. He wanders. What happens in the vagus nerve does not stay in the vagus nerve. The vagus nerve is a wanderer, okay? The rest of the fibers are S2, S4 pelvic nerves, okay? But 3, 7, 9, and 10 are parasympathetic nerves. These are motor, parasympathetic, oculomotor, facial, glossopharyngeal, and vagus all contain parasympathetic motor nerves. There may be also some, like facial also has somatic motor in it, but that neuron that's in there, there are parasympathetic motor neurons in there, okay? Now, there's also parasympathetic innervation as well. Now, how we saw here was we saw that we have ACH, acetylcholine. ACH stands for acetyl. Let me erase that. There we go. It's being slow on me. It's not wanting to work very well. Acetylcholine. Acetylcholine. That is cholinergic. Now, ACH can go to one of two kinds of receptors that are parasympathetic receptors. Parasympathetic. Okay? This would be mostly parasympathetic. Now that we'll see that some of these are more than that, but the cholinergic receptors here are going to be what is referred to, guys, as nicotinic, or just N, and M, muscarinic. Nicotinic or muscarinic that acetylcholine can bind to. Now, they act very differently. Now, nicotinic receptors, these are nicotinic acetylcholine receptors here. Here we have nicotine, the agonist, or acetylcholine binds to the receptor protein, this receptor site, the binding site, and it acts when it binds as a protein channel that opens up these channel gates that let sodium flow through it. When it binds, it opens up and sodium can go through. That is referred to as a nicotinic acetylcholine receptor. Now, the neuromuscular junctions and neuroglandular junctions have ACH. So neuroglandular, neuromuscular junctions found in parasympathetic, they all have the parasympathetic, neuromuscular, neuroglandular junctions. That means smooth muscle, cardiac muscle, and glands here have ACH. And parasympathetic primarily uses ACH. But nicotinic is found in all ganglionic synapses and all in both it's ganglionic synapses in sympathetic and parasympathetic, and all somatic NMJs. Okay? Nicotinic, though that acetylcholine is used in the effectors, in order for sympathetic, you will find that nicotinic receptors, which opens chemically gated sodium channels, because they are stimulated by nicotine and acetylcholine, are found at all ganglionic synapses, whether it is sympathetic or parasympathetic, and all somatic NMJs. Now that's a big deal, okay? It's a big deal. Then muscarinic is found only on the effector cells that controlled by parasympathetic, and their G protein. Here we have G protein linked stuff. These little complex of alpha, beta, gamma subunits will get broken off and whoop, go off. They can be excitatory or inhibitory depending upon what proteins are here. Okay, now muscarinic. Now, let's take a look at this, okay? What I'm going to draw out, and then we're about done, is something here I want to draw out and talk about it, is here. Now, let's go back and do a big review over everything we've seen. And let's start off with sympathetic neuropathway, sympathetic neurons, and let's talk about the normal or neural sympathetic neural. Now, here we are. We have this CNS here. And what I'm going to do, so we know it's CNS, is make it a little bit simpler. This is something my students have asked me in the past to do, is just go like this. Is sympathetic. And let's start with a preganglionic neuron. Now, this preganglionic neuron here is thoracolumbar. And remember, it is relatively short, and then we're going to have a ganglia. Then you're going to have another cell here that's relatively long, and then we're going to go to the effector cell. Here, the effector cell, let's just say the effector cell here is heart effector. Now, this neuron right here is cholinergic. That means it releases ACH, acetylcholine. And let me fix that. That should be a different ACH. Should be a capital C. ACH. Now, that means we have receptors here that are all, the receptors found at all ganglionic synapses are nicotinic acetylcholine receptors. Nicotinic. Now, sympathetic, remember, we have an adrenergic neuron. Adrenergic. That means this neuron here releases epinephrine or norepinephrine as its neurotransmitter. And it's got to have receptors on the heart here. And that's going to be alphas or beta adrenergic receptors. So this one is an adrenergic receptor here releasing epinephrine or epinephrine. So the preganglionic neuron is short, cholinergic, releasing acetylcholine. The acetylcholine then binds to the nicotinic receptor in the ganglia, depolarizing, stimulating the postganglionic neuron, who is adrenergic, which ultimately releases epinephrine, norepinephrine. And then that goes to the target cell, the effector cell, smooth muscle, cardiac muscle glands, or adipose, and uses a alpha or beta receptor. Now, the other sympathetic pathway we saw, sympathetic, was the suprarenal medulla. And the suprarenal medulla here is a little bit different. So if we started off back in our CNS, let me just kind of clean him out. Here, remember, we are dealing with not craniosacral, but thoracolumbar. And we're going to start off here, and we're going to go all the way out, fairly long, to where we go into the suprarenal medulla. Right here, the suprarenal medulla is this triangle. Now, in the suprarenal medulla here, there will be another neuron, and he will be very short, and he will release his neurotransmitters into the bloodstream here. Then we can go to our target effector cell here, the effector cell like the heart. Okay, so let's take this guy. Now, the preganglionic neuron here is cholinergic. That means ACH is released here. Now, given that if ACH is released here, we need a receptor to bind. Now, that means these receptors that it's binding to are nicotinic. Why? Because all ganglionic synapses and all somatic NMJs have nicotinic receptors. So if this is a ganglionic synapse right there, that's nicotinic. Now, this next one here, this postganglionic cell, here releases epinephrine, norepinephrine, norepinephrine. That means it is adrenergic. Adrenergic. And I'm sorry that I'm not being able to write very well on my iPad here. It's adrenergic. And that adrenergic neuron releases in the blood where it then makes it to the effector cells and combined to the receptors, the alphas or betas. Alpha or beta receptor here. So suprarenal medulla, remember, has long pre, short post, whereas the neural pathway, short pre, long post. And the suprarenal medulla is the only place that differs. Now let's look at parasympathetic. Parasympathetic, if I'm here in my CNS, can be craniosacral. Now this neuron here will be very long and it will be cholinergic. That means it releases ACH here as a neurotransmitter. And it's going to bind to a fairly short postganglionic cell that's going to go to the effector here. Now, this effector here happens to have some receptors as well. So let's look at the receptors found here. If this is a ganglia, all ganglionic receptors have nicotinic acetylcholine receptors. So this is a nicotinic receptor, nicotinic acetylcholine receptor. Now the postganglionic cell here is also cholinergic, which means it releases ACH, and here we need a muscarinic receptor. Sorry, I'm going to have to get 1 second here. I'm going to have to get rid of all that. It won't let me pause until I do. Okay, I'm back. Okay, cool beans. It's working. So it's muscarinic. Now, I know that's a little bit annoying, but follow with me, and we're going to go over it again. So sympathetic, suprarenal medulla, and parasympathetic pathways. We are starting in the CNS. Now, the preganglionic neurons are always going to be cholinergic, which means they always release acetylcholine. And in the ganglia, at the ganglia, we have a nicotinic acetylcholine receptor, always. So now sympathetically, we are going to be different, is that the postganglionic neurons are adrenergic, releasing epinephrine and norepinephrine. Now, the effector cells will have an alpha or beta receptor on them. That's really it. Parasympathetics have a cholinergic at the start, nicotinic, to the postganglionic neuron, who is also cholinergic. So that means parasympathetic uses only acetylcholine. And at the effector cell, acetylcholine binds to a muscarinic receptor on the effector cell. And I've drawn it out this way. Sympathetic neural pathway, a cholinergic neuron releasing acetylcholine, binds to a nicotinic receptor, causing an adrenergic neuron to release epinephrine or norepinephrine, and that binds to an alpha or beta receptor on the effector cell, smooth muscle, cardiac muscle, glands, and adipose. Now, sympathetic could be here. We start with a stimulus going to a cholinergic neuron, releasing ACH, acetylcholine, binding to a nicotinic receptor at the ganglia, where this guy releases epinephrine, norepinephrine into bloodstream, and that travels to the alpha and beta receptors located downstream using blood from the suprarenal medulla. All right, and then parasympathetic, we have a cholinergic neuron releasing acetylcholine to a nicotinic. Nicotinic stimulates this cholinergic neuron to release acetylcholine. And then on the effector cell, we have muscarinic. Now, I'm going to ask you guys on an exam. You are going to see either muscarinic and nicotinic. So that means you're going to see one cholinergic neurotransmitter receptor, one cholinergic receptor, and two sympathetic receptors. That means you're going to see alphas and betas, both. You'll see a question about an alpha, a question about a beta, then you're going to see questions about a nicotinic or a muscarinic. And I'm going to go ahead and tell you that now, okay, on my test. Okay, and here's a breakdown of some more things that it does, more detail, but right here is my list to help you kind of learn it that way, okay? Now, the last few things are kind of simple, but that is the big meat that we've just done. So using these drawings in this text, you can get yourself through where these things are. You need to know where they are, the receptors and the neurotransmitters, where they are, what's going on here, okay? And if you understand your basic neurophysiology, then we understand that when a neurotransmitter binds to this, we form an accidental here, and that causes the neurotransmitter to cause a change here. What's happening here is somewhat like what might have happened with a muscle cell contracting or a gland secreting. Something like that's going to happen, okay? Now, there are 6 autonomic plexuses that you guys need to know. Cardiac, pulmonary, esophageal, celiac, inferior mesenteric, and hypogastric. Now, let's start off. Cardiac plexus controls the heart. Cardiac, heart, easy enough to remember. Cardiac deals with the heart. To control the lungs, pulmonary plexus. Pulmonary, lungs. Esophageal, it is vagus nerve surrounding the esophagus. A lot of people are worried to get in here because you might nick some of the esophageal plexus and cause some problems when you work in the posterior mediastinum. Celiac plexus, belly. Celiac plexus right around here. The celiac plexus, or the solar plexus we call it, controls abdominal organs. So if you guys get hit in the belly and you have your wind knocked out of you, you've traumatized celiac plexus or solar plexus. Every time I hear that, it always makes me think when I was a teenager and I watched pro wrestling as a teenager, and the guy would be like, right in the solar plexus. I always remember that. But if you've ever had the wind knocked out of you, you've traumatized a little bit the solar plexus. And it controls with that the inferior mesenteric and hypogastric plexus. Along with that, controls abdominal cavity. Now, the hypogastric gets in to control reproductive, urinary, pelvic wise, but also digestive. And his hypogastric plexus is very important when it comes to things like this is why hypogastric plexus plays a role why people who are on depression, anxiety meds, especially tend to get like upset stomachs, diarrhea, and constipation. Why those symptoms are involved in selective serotonin reuptake inhibitors, things like that, is that it affects the serotonin on part of the hypogastric plexus, which can turn up and turn down the hypogastric plexus activity. See, serotonin works on the synapses here as a presynaptic facilitator inhibitor of these synapses found on the autonomic plexus, especially hypogastric. A lot of the body, we call the hypogastric plexus the second brain, and a lot of drugs work on that to cause people to have upset stomachs, diarrhea, constipation, overactive or underactive gut. And why you will see that it messes with the serotonin, which messes with the digestive control at hypogastric plexus. Okay, this is why. Now, dual innervation, I just briefly want to mention it. Basically, the autonomic nervous system needs to have less a resting level. Even without being stimulated, there's a resting level or autonomic tone. The resting level. It's very important to maintain background function, just normal function. But it can be increased or it can be decreased. Now, there's normal background activity, autonomic tone. Then we can increase it or decrease it. And because of that, to do this, there are sympathetic and parasympathetic on some organs. For example, acetylcholine, parasympathetic, slows the heart rate down. Norepinephrine, now I don't talk about varicosities. Norepinephrine, norepinephrine by sympathetic division accelerates the heart rate. So you have these two opposites effect where the heart receives acetylcholine and receives norepinephrine to get the heart rate up or down. Parasympathetic keeps the heart slowed down, and sympathetic keeps the heart rate high. Together, if these are released in small amounts, there is autonomic tone, normal resting heart rate. But, so parasympathetic slows it down less. That's a normal rest. But if you're in crisis, sympathetic stimulation takes over, and it causes parasympathetic to be inhibited, and the heart rate goes up. And that is, now we also talk about visceral reflexes. We will get into some visceral reflex later on. Pupillary reflexes, gag reflexes, defecation reflex, urinary reflex. We'll talk about the urination reflex and the defecation reflex later on. But these all involve basically some kind of receptor, just like a normal reflex, a sensory neuron, a processing center, and two motor neurons. But these are visceral motor neurons. So, in this case, let's say that a stimulus was fecal matter distending the rectum. Well, we can stimulate a reflex to remove that and respond by defecating. Okay? Now, they're modified, inhibited, or facilitated by things like the hypothalamus, but they're automatic control motor responses for the autonomic nervous system. If it's automatic visceral reflexes, remember, is an autonomic reflex. If it's a somatic reflex, it's a skeletal muscle reflex, but still unconscious. Now, there are long reflexes, and I want to talk about long reflexes. They have CNS component. Short reflexes bypass the CNS, so they have no CNS component. Beyond that, that's all I want you to know about them. We'll talk about long and short reflexes and how they are involved in moving food through the gut. But this concludes autonomics. As you go through this specifically, make sure you guys go through these chapter objectives. Make sure you pay attention specifically to the sympathetic and parasympathetic neurotransmitters and receptors. Those are very big, long haul, long-term things. And these drawings right here that I've done and the drawings that I've done through here will help you at trying to do that. And if you come to our study group, I'm going to help you guys get through that by having you do this as well. So review those things, rewind the recordings and go back over them and stuff like that. But this concludes our first chapter. Now, once you do this, I'll go ahead and do the quizzes. Thank you guys so much.